So I'm McKenna Byerly. I'm with the CME department. So I just wanted to welcome you today, and I will get started by introducing our speaker, Dr. Callahan. So Dr. Tamara Callahan is an honors graduate of Harvard Medical School, where she's currently her class agent and vice president of the Harvard Medical School Alumni Council. A dual degree graduate, she also earned a master's in public policy with a concentration in healthcare policy and management from Harvard's John F. Kennedy School of Government. Dr. Callahan completed her residency training in obstetrics and gynecology at Brigham and Women's Hospital and Massachusetts General Hospital. After over 15 years in Boston, Dr. Callahan joined the faculty at Vanderbilt University Medical Center in Nashville. During her 10 years at Vanderbilt, Dr. Callahan served as the medical director of ambulatory obstetrics and gynecology and as the director of quality and patient safety. She was promoted to associate professor of clinical OBGYN at Vanderbilt in 2015. She has served on multiple state and national advisory boards and has been designated a top doc in Nashville on multiple occasions and has earned 5 national 5-star patient satisfaction awards. Dr. Callahan joined the Norton Women's Health Practice in Louisville, Kentucky in October of 2018. She specializes in gynecology with a special interest in abnormal pap smears and cervical pathology, uterine fibroids, abnormal uterine bleeding, PCOS, complex contraception, and benign vulvar disease. And she is happy to be taking new patients. And Dr. Callahan has no relevant relationships to disclose. And so with that, I would like to turn the program over to Dr. Callahan. Thank you so much for being with us, and I will turn it over to you.
Hey, thank you for having me. Well, welcome everyone, and thank you so much to the CME team and to Mary Schubert, my Vice President of Women's, and for you all for coming back. We tried this once before, and I apologize for our technical errors, but hopefully we'll have a good, productive meeting today. I am going to be talking about a practical guide to the management of perimenopause and menopausal women. I do write 2 textbooks and receive royalties for those, and I'm a written and oral board examiner for the American Board of OBGYN, but I have no financial relationships to disclose. So today my goal really is to give a good overview of the reproductive aging stages throughout life, to look at the symptoms of both perimenopause and menopause, and in particular to focus on vasomotor symptoms and genital urinary symptoms, as those are some of the most common that women have. I want to drill down and look at the behavioral versus non-hormonal versus hormonal management of these symptoms. And my goal in the end is that you'll have some take-home go-to regimens that you can use for the treatment of hot flashes and night sweats, and to feel comfortable that you're doing the best thing for your patients. So starting off with a few definitions, menopause is a definition that's made in retrospect. So basically after that final menstrual period that occurs naturally and due to the cessation of ovarian function, after 12 months of amenorrhea, then you have the diagnosis of menopause. Perimenopause, on the other hand, are those years leading up to menopause. And in many ways, we used to think this was a short period, but now we know it could go anywhere from months to 4 to 8 years in time. And just to clarify, early menopause are women who have that last period and meet the diagnosis of menopause, but they're age 40 to 45. That's not a pathologic diagnosis, it's just early menopause, just something to note, but considered normal. Induced or surgical menopause is menopause due to surgery, a bilateral oophorectory will give you that diagnosis. And postmenopause is that state of life going starting at menopause and goes throughout the rest of life. There's no ending to the postmenopausal phase. And I also want to just flag premature ovarian failure, which we know is now been renamed as primary ovarian insufficiency. And those are women who go through menopause before the age of 40. And many, so that's a special category that is indeed menopause, but it's due to primary ovarian insufficiency. This is just a quick slide to let you know that some very smart people got together in a room and went through really categorizing the various phases of reproductive health. Jan Hall, who was one of my mentors in reproductive endocrine at Mass General, took a large part in this, and she was the president of the Endocrine Society. So all of those very specific bleeding patterns, the hormone levels are all there and have been modified as well. So why do we even care about menopause? Well, I think one reason is that there's so many women who experience it. Currently, there are about 75 million women in the United States who are postmenopausal. And given our life expectancy, that means that North American women are going to spend 1/3 to 1/2 of their lifespan in menopause. And so as providers, it's really important that we understand how to manage those phases well and how to educate our patients. Because these patients want to be active, they want to be physically active, professionally active, and they want to live a high quality of life. But those symptoms that are involved in perimenopause and menopause can really be distressing and have a true impact on life. We know that at least 84% of women feel that their menopausal symptoms interfere with their life, and 42% of them never discuss their symptoms with a provider. And then I have to be honest, there's also the phenomenon of the women who do discuss their symptoms, and they come in and this is what it looks like. And you guys have all heard this. Doctor, my hormones are out of whack. And I'm telling you, when I see that, I hear that, I have to put myself into my mindfulness mode. I do some deep breathing because I still have this very visceral reaction to say, they're not out of whack. This is a normal process. But then I have to remember that these symptoms really are so ubiquitous and very distressing that it's important to get over my little, it's a terminology issue that bothers me more than anything, and really step up to help the patient. And so I think most of us, this slide will see a lot, which sort of just says, estrogen is important to the body. It's important to all parts of the body. And as a result, we get a lot of symptoms in menopause and in perimenopause. Most of us are pretty familiar with and comfortable with some of the menstrual cycle changes, the hot flashes, night sweats, decreased libido, vaginal dryness, and dyspareunia. But the other symptoms that kind of overlay into that are weight gain, that brain or mental fog, mood swings, urinary leakage and frequency, sleep disturbances, and then of course the things we can't see, but osteoporosis and cardiovascular disease. And as you can see here, the percentage of women who have the symptoms are very high, and most women have multiple symptoms. I want to clarify, I'm going to speak about perimenopause and menopausal symptoms together because in many ways they are very similar. And in fact, many of the symptoms are more intense during the perimenopause phase than during menopause. So just to compare and contrast, menopause, the average age, in some places you'll see it, the median age is 51. But that range can be anywhere from 40 to 58, with most women in that 45 to 55 range. I just want to flag too, for women who are of Ashkenazi Jewish descent, they do have a mutation in the apoptosis gene for the ovary. And so many times their menstrual cycles will extend beyond that age 55. And during menopause, we know that the ovaries stop producing estrogen, you stop ovulating, and therefore you're not bleeding. The diagnosis is made after 12 months of spontaneous menses, of no menses, rather, spontaneous amenorrhea. During this time, pregnancy is not possible. There's no endpoint, and really the symptoms come from estrogen deficiency, as opposed to perimenopause, which typically involves women in their 40s, which is often shocking for women. When I start to talk about in my annual visits in anticipation of those symptoms, you can tell that women are kind of taken aback. But I think the education piece is really important. And so I start talking about it early. We know that perimenopause can go from months to even years, even up to 8 years before final menopause, the final menstrual period. We know that during perimenopause, and this is one of the biggest difference between the two phases, the ovaries can still make estrogen and progesterone, but it's just erratic. It's that up and down nature of that makes the symptoms so intense. And sometimes it's harder to put the whole picture together, because some months women do just fine. They ovulate, they make plenty of estrogen, and then other months they don't. It's important to remember that pregnancy is definitely still possible during perimenopause. And one of the other things I want to flag too is just that we're used to thinking about skipped cycles in perimenopause, but actually before you skip cycles, they will often become closer together and heavier. And then you start to go into oligomenorrhea. And that's really due to that irregular estrogen production. And again, just flagging that perimenopause can have more symptoms even than menopause. This isn't a great picture. It's just meant to show that on the top side here, if you're not ovulating, you're not making estrogen, you're not making progesterone every single month, but it's erratic. And so sometimes you will bleed and have, and sometimes there won't be bleeding, as opposed to postmenopause, where there's minimal estrogen release. And so you really aren't getting thickening of the lining and you're not getting bleeding. So bleeding becomes one of the first issues that occurs during perimenopause. And so if you look at my left-hand side of the screen, you can see that bleeding patterns during perimenopause, you can get heavier cycles, you can get closer cycles, you can get oligomenorrhea, and then you add hot flashes and night sweats with that. So you really do have to do a little bit of, well, more than a little bit, just really looking at a differential diagnosis. So obviously with heavy periods, this also happens to be a time of life where you see more polyps, more adenomyosis, more fibroids, more hyperplasia. So you do have to make sure that you're ruling those things out. For oligomenorrhea and amenorrhea, you want to think about pregnancy, PCOS, thyroid, prolactin. For hot flashes and night sweats, again, thyroid, diabetes, primary ovarian insufficiency, and then some of the more rare things. And then mood swings and insomnia. This is also a time of great life stress. So you can have mood disorders, medications, sleep apnea that impact mood swings and insomnia. And then weight gain. That's one of the biggest distressing complaints that women come in with. And it can be a normal part of aging as our physiology changes, but you also want to look for hypothyroidism, metabolic syndrome, and diabetes. And then when there's vaginal and urinary discomfort, you can look for these other things as well. So really for me, when a patient comes in, I try and get this gestalt of what's going on with their bleeding pattern. And sometimes that can be tricky because so many women have IUDs or levonorgestrel IUDs, have had ablations or have had hysterectomies. So that takes one of this triad pieces away. But I look at bleeding pattern, I look at the symptoms that they have, and then I use my objective data. So looking at the labs, the ultrasound, and often an EMB is necessary as well, an endometrial biopsy. So these are typically when I see someone, this is how I start out. I'm looking, make sure they're not pregnant, checking a CBC, are they anemic, they're complaining of fatigue, or how's their platelet count in their CBC if they're having heavy periods, looking at their thyroid function, prolactin, and a hemoglobin A1C. And then here's the stickler, hormones, to test or not to test. And I have to say, I've been in practice 20 years now, and in my younger days, I was a real hard-nosed, I'm not getting hormone levels, your hormones are fine. And now I've kind of pushed back a little bit and really try and meet the patient where they are. I don't get them willy-nilly. If someone's having a regular menstrual cycle, I said that is the best indication that your hormone levels, or your reproductive hormone levels to be more specific, the ones that they're referring to, are just fine. But if they're having oligomenorrhea, they're having hot flashes and night sweats, it's nice sometimes just to have verification that that FSH is elevated. And that's usually the most helpful thing for me. But I always educate them and tell them, listen, this is a lab result that's good for today. It doesn't have anything to do with what your lab results will look like tomorrow. Also looking at vaginal cultures, a lot of times when women are having dyspareunia or vaginal dryness, just making sure there's no yeast, bacterial vaginosis, checking the urine, and checking STIs, because a lot of times women are no longer using protection or birth control, so you want to just make sure that there's not a sexually transmitted infection there. I will often get an ultrasound looking for the fibroids, looking for polyps, and also looking at that lining of the uterus. Is it thickened? Is it thinned? Am I worried about hyperplasia, given that they're having oligomenorrhea? And for women who are 45 or above with irregular bleeding, so bleeding too much, not bleeding enough, skipping periods, bleeding after sex, bleeding after menopause, they do need an endometrial biopsy. That used to be age 40, but several years ago, maybe in 2012, that switched over. And the other thing that goes with that, any woman who's high risk for a hyperplasia or a cancer, so morbidly obese, lifelong oligomenorrhea, needs to be biopsied regardless of age. And this is also a good time for me to just check and make sure we have birth control on board. Usually when I pull out that pregnancy test, they're like, why are you testing for that? And so it's easier to kind of talk about contraception at that stage. So there are things you can do to impact the menstrual cycle and your experience of it. Certainly the healthy diet and exercise and normal weight and reducing stress, all the usual things we talk about are important, but there's also medical things that we can do. And one of the things I want to flag here is, especially for perimenopause, when women get to that point where they're really skipping cycles, the use of a continuous low-dose OCP is really a great friend. So when I say continuous, meaning they're taking a hormone pill every day. So instead of having that up and down of erratic hormone levels, they have that low dose of continuous birth control pill. And I let patients know, the amount of hormone in these for those who are not who do not have contraindications is much lower than what your body would naturally make. And then hormone replacement or menopausal hormone therapy is even lower than that. Because I think sometimes they get it reversed and it's like hormones. So of course we want to make sure there's no contraindications. We typically after 40 will use a 20 microgram pill and use it in an extended or continuous fashion. We use a lot of Lystet in these women, as well as the levonorgestrel IUDs and endometrial ablations, which can be used for women who have menorrhagia, so heavy regular periods. A lot of times, women want to treat the bleeding well before they're able to make it to 12 months of amenorrhea. So there is some medical or surgical intervention. And I don't shy away from talking about hysterectomy, mainly to point out, number one, most or many, a lot, depending on where you are, of hysterectomies are done laparoscopically, that we do not have to take out the ovaries. We do take out the tubes now to decrease the risk of ovarian cancer, and the recovery time is a lot better. So I'd like to give a woman sort of talk about the hormonal interventions, and then I'll usually talk about IUD ablation and then hysterectomy. So once we kind of have the bleeding figured out, the next big thing that comes up is usually hot flashes and night sweats. So together, these are known as vasomotor symptoms. And we know as many as 87% of postmenopausal women are going to have hot flashes and night sweats. One of the things we want to think about in terms of normal physiology is this thought that as we age, our thermal regulatory, sometimes they call it a thermal neutral zone. So that zone where we're comfortable temperature-wise actually decreases as we age. So at temperatures where we used to be absolutely fine, now we'll be cold or hot. And therefore, little changes in the core body temperature will trigger into hot flashes and night sweats, which can become recurrent and vary in intensity and in the number. So women are very individualized. And the treatment that they're going to choose is going to depend upon their symptom severity, as well as their risk factors and their personal feelings about menopause and medication. We don't necessarily want to medicalize a normal process, but at the same time, you have to be able to do life. So I put this little cartoon down in the bottom because I remember one of my patients early on when I was first in practice, and she was CEO of her company, and she would literally have these hot flashes where she would just drip sweat. And she said, Dr. Callahan, 4 times a day, I have to go to the bathroom, wash my face, reapply my makeup, because she wanted to have, her look, her CEO look on, and that's what she enjoyed. And more so just also being in front of people having this going on, where visibly a lot of times you can see women will break out in sweat, their cheeks will get all red. The North American Medical Society does this nice illustration in their menopause curriculum where they show what goes on during a hot flash. So basically you have this adjustment in your core body temperature, you get increased blood flow to the skin, the heart rate can increase, and then you get this intense feeling of heat that radiates into the, usually from like the chest and into the face and head. You can also feel anxiety and clamminess, and then you get this peak in the heart rate and a peak in blood flow. And so you start to perspire. For some women, that's very visible. For others, you just feel like you've been set on fire from the inside out. And then as it dissipates over about 5 minutes, you can get the chills. And so you can imagine at night when you have this intense heat while you're sleeping, you wake up, you yank the blankets off, but then you end up with chills and you're cold. So then the blankets go back on, blankets on, blankets off, blankets on, blankets off. That can be so disrupting to sleep. And so some of the risk factors for hot flashes and night sweats include smoking and obesity. Obesity, I find an interesting one because we really think that with peripheral conversions of androgens to estrogens in the adipose tissue, that obese women would have fewer, but they think it's more of an insulating impact of the adipose tissue that makes that heat trapped on the inside. Women of color, tend to have more hot flashes and night sweats. Women with a history of PMS and women with a positive family history will have more as well. Some of the triggers are just being in a warm environment. Warm foods, warm drinks, spicy food will often trigger these. Alcohol, especially red wine, can trigger, and caffeine, tight clothes. And the other one that's really tough is stress. So you get in a moment where you're stressed or you're concerned or you're upset, and then on top of what you're dealing with, you get the hot flash coming on as well. So the way I'm going to look at the treatment of hot flashes and night sweats is kind of to divide it up into behavioral and lifestyle changes, and then into non-hormonal treatments, hormonal treatments, and I want to talk a little bit about bioidenticals and compounded meds. And so in terms of behavior and lifestyle things, I think education, and you'll keep hearing me say this, is so important, not only of the patient, but also for their partners and family. There is a book by Tara Allman, Allmen, and I get no royalties or kickbacks, but I just like it as just a basic, really good book for women to kind of go through all the different symptoms that occur with perimenopause and menopause. Other triggers, alcohol, caffeine. So you want to avoid the triggers. When you educate them about triggers, then they can avoid. Layering of clothing. Once again, I have my light black sweater on. It's a thin one, so I can take it on, take it off. You can roll it up, put it in your bag. It's still wrinkle free. That really makes a difference in how comfortable women can feel. And then lowering the temperature. This is often, women will come in like, I fight at work, I fight at home. I want the thermostat down and other people want it up. Having a little personal fan is helpful. There's something called a chillo, which is a gel pad that goes in your pillow, between the pillowcase and the pillow, that helps to cool the face and give more of a comfort feel at night. There's cooling blankets, and there's even some sweat wicking pajamas and sheets. So those are the non-hormonal, the behavioral and lifestyle changes. And by now, most of us know that there are non-hormonal or non-estrogen treatments of hot flashes and night sweats. And so we know that the SSRIs and SNRIs can be used. Paxil given at those low doses, 7.5, as the brand name Bristol is the only FDA approved one, but that we use most of them off label. Gabapentin as well, Lyrica, and Clonidine. All of those have been shown to have some effect, even given that the placebo effect for a lot of this is kind of high. It's like 50%, but they have effect beyond that. The things that we've seen over the years that don't seem to have, that we don't have a body of evidence for, that they've been efficacious, are for soy products, a lot of the herbal remedies, the vitamins, acupuncture. This doesn't mean that they don't help or don't work. It just means we don't really have the body of evidence to show that. So drilling down a little bit more specifically into the SSRIs and the SNRIs, I'm going to flag a couple things. One, again, the Bristol or Paroxetine given at that 7.5 milligram small dose is the FDA approved SSRI. But we know that most of the SSRIs are equally efficacious. I tend to use Lexapro a ton just because I'm comfortable with it. I like it. It's a cleaned up version of Celexa. It has a little baby 5 milligram dose, but use what you're comfortable with. And I know you guys use these products all the time. Also, I just want to flag that sertraline and fluoxetine actually have not been found to be efficacious in terms of treating vasomotor symptoms. So basically, we don't use them for that reason. And one little flag on Effexor is that the studies show that the 75 milligram dose, if you increase it to 150 milligrams, you get only a tiny bit more effectiveness, but you get a lot more side effects. So it's really the 75 milligram dose that works well. And then I think, again, you guys use gabapentin. I don't need to preach to the choir, but it has been found to decrease both the intensity and the number of night sweats in particular and hot flashes, but it's really great for women who are having more night sweats. Typically, we use it in these small little doses. I'd say the vast majority of my patients that take it at night are on 100 or 200 milligrams. When you look at the literature for hot flashes and night sweats, they will go up to 900, but typically that's not needed. Most folks are in the lower doses with some that might need 300, some might need 600, and then really just watching for side effects with that as well. When they've done head-to-head, women, and they've done the trials where you switch arms, women tend to like Effexor more than the gabapentin, but I've used both with really good results. Clonidines, a oldie but a goodie. The take-home on Clonidine is usually we try and use the patch version of it if we can, just to get those stable levels. And just watching for side effects like dry mouth and insomnia. It does show some minimal effectiveness over placebo. And then honestly, I haven't used Lyrica for hot flashes and night sweats, but if you look at the literature, it's sort of the same thing as we see with Effexor, which is the 75 milligram dose. If you increase it to 150, you will get a little bit of increase in effectiveness, but but you get many more side effects. So here's the grand dame, hormonal treatments of hot flashes and night sweats, which really we think of as the crux of really menopausal hormone therapy. And so just to start off with a little bit of terminology, both in the US and Canada, hormone therapy is approved for the treatment of menopausal symptoms and vasomotor symptoms specifically. Hormone therapy encompasses both estrogen alone and then estrogen along with progestin therapies. So estrogen alone therapies we're using in women who do not have a uterus, and when you use it in the form just for vaginal, non-systemic, but localized treatment. And you really have to separate those two for patients because they'll start to read about all the estrogen side effects. So when you're using just vaginal, it is a whole different creature than when you're using systemic estrogen. And then estrogen used with progestin therapy is mandated in women. If you have a uterus, we need to protect the uterus from endometrial cancer, and we do that with progesterone. And then in the end, we'll speak a little bit about bioidentical hormone therapy and those that are FDA approved and tested, and then those that are less tested and coming from compounding companies. So MHT is the new HRT. So we used to talk about hormone replacement therapy, and now we talk about menopausal hormone therapy. One of the main things in that phrase is menopausal. These are things we're using in women who have gone through menopause. Occasionally, patients will come to me and they've never really been diagnosed with menopause. They're still obviously perimenopausal. And so in those women, we're going to use those other treatments we talked about before, like a low dose birth control pill, as opposed to menopausal hormone therapy. So what I'm going to give you now is going to be from the American College of OBGYN and the North American Medical Societies. Those are kind of the leading organizations around this issue. And one of the things they say is that systemic hormone therapy is the most effective therapy for vasomotor symptoms that are related to menopause. We know this, but what makes this hard is trying to give good, safe, individualized therapy to patients. And so I'm not going to go through all of the studies. They're there for your later reading, but I just want to, this sort of speaks to how we've had this big pendulum swing in menopausal hormone therapy, where we've gone from days when everybody was on it, you stayed on it for your entire life, and then we only took you, we even started to look to see, well, maybe these are even helpful and preventative hormones. And then WHI came out and really kind of threw cold water on all of that. And then women just, the level of menopausal hormone use dropped off tremendously. What WHI said was that there was, when you use estrogen and progesterone, there's an increase in thromboembolic events, DVTs, PEs. There's an increased risk of cardiovascular disease, stroke, and breast cancer, even though there's a decrease in fractures and colon cancer. When women were using estrogen only, they didn't have as many of those side effects. There was increase in thromboembolic events, but no increase risk in cardiovascular disease and breast cancer. So what we know about WHI, and you've all heard this, so I won't go on in too much detail, is just that it looked at such a broad array of women at older ages that it really wasn't applicable to younger women who were newly starting off on hormone replacement therapy. And now as they've, and also they really only use sort of one estrogen and one type of progesterone. And so you can't really extrapolate about the other types that we use. So beyond the WHI, we know that after a huge review, we really just still don't use these medications for the primary or secondary prevention of disease, because simply the risk outweigh the benefits. So what do we know today? What can we do? And these are just sort of the take-home bullets from the North American Menopause Society. We know that the route of administration and the timing, like when you start, really does impact the outcome. We know that for healthy women in that 50 to 59 range, that there are some slight increases in thrombosis and stroke and cardiovascular events, but really they're pretty small. And so that group is pretty safe, especially when you start hormone replacement therapy or menopausal hormone therapy within the first, within 6 years to 10 years of menopause. When we go beyond that in older women, then the risks get very high. We do know that when you're using combination hormone therapy, that breast cancer risk is increased, and that you can, because it's not increased with estrogen alone, you can use that for longer periods of time. But they really start to talk more and more, and for us as providers, it can be frustrating because they talk about individualized, look at the woman's priorities and risk factors. And ACOG agrees with that. They have gone on to say that because some women, even age 65 and older, will continue to have symptoms that they may continue to need systemic hormone replacement. And so they don't recommend routinely discontinuing at age 65. And I'm telling you, if Karen wouldn't kill me for putting in another slide, it would have that big emoji with those eyes that just look out at you like, huh? That would have been the next slide. It goes on to say that we really, again, have to individualize therapy and look at the risk-benefit ratio and clinical presentation. I think many of us find this extremely frustrating because you want those nice, tight guidelines, but really this kind of leaves it. It says you need to educate, you need to talk, you need to discuss, and you need to document, basically. So how do you make, if you look at all these different formulations, how do you make heads or heels out of this? And really, it's important probably to know, as important, who not to use menopausal hormone therapy in. So these are the contraindications: the estrogen-sensitive cancers, active liver disease, PEs, DVT, history, undiagnosed vaginal bleeding, and then some relative contraindications. So I kind of boil it down to these are my go-tos. So I have my oral estrogens. So they're the conjugated equine estrogen, that's Premarin, and the micronized estrogen, which is a bioidentical actually, is Ssris. And these are the doses I start with, and then I can go up a little or down a little depending on the woman's needs. Whenever possible, you try and use transdermal estrogen because it's thought that it decreases the risk of thrombosis and also decreases the negative impact on cholesterol. The estradiol Climera version of the patch is usually weekly, and then there's one that's twice weekly, and that's really just patient specific and what their insurance will pay for. But I usually try and offer one of these, and then I pick a progestin if they have a uterus. If they don't have a uterus, you shouldn't use a progestin. The temptation is want to throw it on for the sleeping, but that's not what we need to do, because we know that the combination of estrogen and progesterone does increase risk. And so you have your prometrium, your micronized progesterone, and then the traditional medroxyprogesterone acetate. I tend to use the micronized bioidentical prometrium. I like that, use it at night. But again, education. A woman needs to understand we're using this to protect your uterus from cancer. Please do not stop this. Let's talk if there's a problem. It's a good reason to have a telehealth visit. So here's my 10-step guide to using hormone placement therapy. Again, educate, discuss, document on the bookends of these 10 steps. One is to determine if the patient is truly menopausal and if they're newly menopausal. So in that first 6 to 10 years, the indication really is, we're not trying to protect your bones or vaginal symptoms, but really we're looking for moderate to severe vasomotor symptoms. So those hot flashes and night sweats. For vaginal symptoms, there's other things we can do. Then we look for our contraindications. Then I look to see, does she have a uterus or not? If there's a uterus, you need progestin. If there's not, you use just an estrogen. So I pick my estrogen, transdermal if possible. Then I pick my progestin. I like to just go to prometrium. It's easy. And I know others I can use if needed. And then you should try and avoid using systemic estrogen along with vaginal estrogen as well. Sometimes you need to, but try not to. You want to get the patient to an effective dose. If it's not a good dose that's helping their symptoms, they're not going to take it. And then when do you discontinue? So is it 5 years? Is it by age 59? Is it even later? So basically I start with 5 years. I try and get them to age 59. And then there are a few women that I have to take later just because their symptoms are severe. There's a question about should we taper off, and really there's no literature to support it. I tend to taper, but I do this teeter-totter method where if they're symptomatic, I try and add on a non-hormonal, I'll add on an SSRI or something like that. So they're off the hormones, but they do have something to control their symptoms. And again, educate, discuss, and document. So a little bit about compounded bioidenticals. Basically, these are mostly plant-derived hormones that are chemically similar in structure to those secreted by the ovary. There is a new FDA approved product, which is essentially Ssris plus prometrium, sold under the name Bijuvia. But the compounded bioidenticals are those that the creams, the gels, and things that are made in compounded pharmacies. And really the FDA and the Endocrine Society really considers bioidentical hormone therapy as really a marketing term. It's obviously appeals to women because they think it's safer, less risky. They want to get that 25 again. So this discussion is an important one to have. Many of these just have not been well studied, and that's part of the issue. So they're not recommended by ACOG for that reason. This was the Bijuva, which is the essentially micronized progesterone and Ssris in one pill. So I can offer my patients bioidenticals. So I'm going to talk a little bit quickly about decreased libido and vaginal dryness, because those are the other big things, and then we'll move towards wrapping up. This is just to say that these changes on the vagina are really real, that there's a loss of cells. You can get thinning, burning of the vaginal epithelium. And you can see the difference here between that well estronized versus the atrophic epithelium of the vagina. And I always bring this up about you have men who may have erectile dysfunction and they're on Viagra, so they have this firmer, longer lasting erection. And then you have women with vaginal atrophy, and it's just not a good combination. That's why it's really important to feel comfortable treating these. Also, just a little nod so that women do get urinary symptoms as well, like incontinence, overactive bladder, dysuria, caruncles. So there's a whole differential diagnosis for that. But using vaginal estrogens really helps with both the vaginal and the urinary symptoms. I'm going to move ahead here. There are lubricants that work well when women have dryness just with intercourse. If they're having dryness throughout the week, you may want to try a moisturizer that's not for intercourse. Replens is one of those over-counters that people use and they like. The estrogens come in a bunch of different forms, and they really work the best. They even work better than the vaginal estrogens work better than the systemic ones. And they come in a multitude of forms. A lot of it just depends on what the insurance will pay for and what the woman's experience is with it, whether it's too messy or what have you, if they want a ring or something that's longer term. So there's a lot of variety there. There's a little bit more detail. The urinary symptoms, this talks a little bit about how we address that, but vaginal estrogen really is the best thing for urinary symptoms as well. A little bit about the menofog. It's a real thing. There is some fogginess, forgetfulness, lack of focus, maybe worse during perimenopause. The differential diagnosis is there, could be just part of normal aging, but other things we need to look for. The SWAN study that I showed earlier does show that there is some impact of estrogen on the hippocampus and affecting memory. So these are some of the things that women can do. One is just to be educated and know that it does get better. Exercise, diet, smoking, all the usual healthy things do help with that. And these new studies, the KEEP studies and the SWAN study, does suggests that menopausal hormone therapy may help with that as well. Our puzzles, as much as I like to think about it, have no clear evidence of benefit. Mood swings, another big issue that comes up. These are abrupt, extreme changes, feeling upset and irritable. Again, women say, I just don't feel like myself. During perimenopause, it can be worse because of the fluctuation in hormones. And you do have to think about risk factors and differential diagnosis for these as well. And again, here are some of the healthy life things that you can do, and not just in a throwing it out there way, but it really is worth it to sort of nail down things you can do to make a difference. Sometimes just treating the hot flashes and night sweats goes a long way to getting good sleep, which impacts mood. And then weight gain, the so-called menopause. So we know that there's a redistribution of adipose tissue to the middle, to the abdomen. We know that over time, from age 30 to age 50, women burn about 500 kilocalories less per day. So we have, and that they think it's mostly due to decreased muscle density, slow metabolism. So really a lot of dealing with the weight issue is education, again, focusing on a long-term plan, ruling out thyroid and diabetes and other sources, and really adding in that strength training. As women, we go straight for the cardio when we want to lose weight, but we really need to get that strength training in there as well. And when necessary, use weight loss experts. So quickly on decreased libido, we don't have a lot of help here because they've taken testosterone away from us as a product we can use. We do have a couple of things we can use that are new for perimenopausal decreased libido, but they're not to be used for menopausal women. So we really still struggle with this. And we know that decreased libido can be multifactorial, but at the same time, it is very disruptive to a couple and for the woman. And again, education is really important for a woman and her partner as well. And so these are the couple of medications that we have now. I honestly have not used them. They're rather new and very expensive. So sleep disturbance, we talked about a little bit before, and you guys know all of this about how to get good sleep hygiene. So it's the same here. All the things that we typically use are used in menopause. And again, treating those night sweats really helps with getting good sleep through the night and feeling rested. And so I'm not going to go into osteoporosis, cardiovascular disease. That's your forte. So we won't go into that, but just sort of recognizing those as kind of the hidden signs of menopause. So, we've gone over a lot of information today. We talked about menstrual cycle changes, vasomotor symptoms, looking at lifestyle changes, non-hormonal medications. We looked at menopausal hormone therapy, how to do that. And we looked a little bit at compounding and bioidenticals, and then talked a little bit about the genital urinary symptoms of menopause as well, because that's important to know how to treat. So I think we've met our objectives for today. So I'd like to just thank you and wrap up there.
Thank you so much, Dr. Callahan. We had a few questions.
Okay.
So the first question, is it possible to practice natural family planning for birth control during perimenopausal period?
I think the difficult part with that is that natural family planning requires you to have regular menstrual periods so you know when you ovulate, so you can avoid that highest risk for pregnancy. And so during perimenopause, you don't know when you're going to ovulate many of the times. So if you're still at that point of having regular periods, yes, but more than likely, I would not rely upon it.
Okay, thank you. Can periods start again after IUD removal if you are 51 years of age or older?
Yeah, it's possible because some women may not be through menopause. You can be 53 and not through really menopause. You're not bleeding with when you have a levonorgestrel IUD because of suppression of the endometrium. But once that comes out, you do ovulate anyway about 50% of the time on an IUD, levonorgestrel IUD. And so, yeah, your periods can definitely come back if you're not through, the definition of menopause.
Okay, and finally, for patients who are on topical estrogen for atrophic vaginitis treatment and has intact uterus, do you recommend adding progesterone?
On topical estrogen, so I think, so there's different formulations. So it depends on, and this is, did you say, I'm sorry, McKenna, it was for atrophic vaginitis?
Yes.
Okay. Oh, and I'm assuming is that, I just am not sure about the question, whether you mean topical like transdermal or whether topical vaginal is usually what we're saying, but you do not need progesterone if you're using vaginal estrogen at those low doses that you use with like a Premarin cream, Ssris cream, Vagifem. They decrease the dose of Vagifem because you were getting a little bit of a systemic level, but you do not need it for the dosing that I showed today. And also you can use it indefinitely, so you don't need to pull back from that. And I just want to make a little bit of a nod for coconut oil, which works really, really well. It kind of soothing as well, works well for intercourse also. So sometimes adding those little tweaks can make a real difference for a couple.
Okay, and then we had another one. Are the 20 mcg birth control pills, Yaz, lower than the Prempro combo as far as the estrogen content goes?
They're usually higher. Yeah, they're usually higher, but you need that to kind of just give that baseline to be able to conquer those symptoms in the perimenopausal patient. And typically what we do, like say we start someone, she's 48, irregular periods, hot flashes, night sweats, you start them on the 20 microgram. Once they get to 51, which is the average age of menopause, generally we may take you off or just transition you straight over to menopausal hormone therapy, so even lower doses.
Okay, and then one last one. If a woman uses an IUD, how do you know if she is in menopause?
So again, it's hard to tell sometimes with the IUD or somebody's had a hysterectomy. That, they're in menopause, but in general, what will happen is they'll have the hot flashes, night sweats, the other symptoms that we have on that big list of symptoms. And you can check hormone levels as well to give an idea of where they are. But I wouldn't take that IUD out, leave that in.
Okay, I think that's all the questions that we had. Thank you so much, Dr. Callahan.
Thank you guys, I appreciate it.
We appreciate you being here. And for all of our attendees today, we will be posting a QR code. We're about to bring that up now that you can scan with your phone, and that will take you to the evaluation where you can claim credit. We've also put that link in the chat for you as well to the evaluation, and we'll also send an email to everyone who registered today to the evaluation. So Additionally, our next Updates in Women's Health, it's going to be on Tuesday, July 13th. The topic is pending, but we will email you when we determine a topic, but we hope you all can join us for that. And if you have any questions, please enter those over in the chat or email cme@nortonhealthcare.org. Yes. Thank you everyone for being here, and please fill out the evaluation. Have a good one.